out of sync. As a result, cardiac output is diminished. Furthermore, this may be confounded by a right ventricle which is contracting out of sync as well. So one way we can do to correct this physiologically is to implant a lead in the right ventricle, one through the coronary artery which stimulates the left ventricle, and pace both the left and right ventricular apex simultaneously to restore synchronicity and also hopefully to improve cardiac output. We know that the CARE-HF trial showed a 30% reduction in mortality over 5 years for people with class 4 heart failure on optimum medical treatment who received biventricular pacing. This is for an apparent very small improvement in blood pressure, a clearly marked decrease in mortality. Next, we're going to move on to talk about tamponade and constriction. Constriction should be considered primarily a pericardial phenomenon. So the pericardium surrounds the outside of the heart, separated from the myocardium by a thin film of fluid. When the pericardium becomes thickened, it becomes like an eggshell around the outside of the heart, preventing nice relaxation of the heart. This can lead to filling abnormalities and a decrease in the cardiac output. It can be caused by tuberculosis, radiotherapy, pericardial malignancy, drugs such as hydralazine, post-pericarditis, which can be viral or bacterial, uremic, or connective tissue disease. Most commonly probably secondary to coronary artery bypass grafting. Tamponade itself is not a problem with the pericardium, but a problem predominantly with the space between the myocardium and the pericardium, which becomes filled with fluid, which may be pus, secondary infection, or commonly blood. When this happens, it markedly impacts on filling, reducing cardiac output. The causes of tamponade are the same as constriction, but also dissection, myocardial infarction, pacing complications, and anticoagulation in acute pericarditis. One of the reasons I mentioned earlier for not implanting a temporary pacing wire in someone and rather going for a permanent system was the fact that as pacing wires are less frequently deployed than they were, people become increasingly inexperienced. The right ventricle is a very thin-walled structure, and it's extremely easy to poke a pacing wire through the right ventricle towards the pericardium. If this occurs, a hole can be created through the right ventricle which allows blood to fill the pericardial space. Following implantation of a pacing wire, which may be successful, one should always be cautious in patients when the blood pressure starts to fall, as this may be a sign that cardiac tamponade has been created. In such scenarios, it would be essential to think quickly, and an adequate pericardiocentesis should help to restore normal blood pressure. The next table shows a comparison between constriction and tamponade. We've listed various parameters including the jugular venous pressure, Kussmaul's sign, pulsus paradoxus, atrial pressures and end-diastolic pressures, and how they're affected by constriction and tamponade. We've briefly mentioned constriction, the fact that this is predominantly a pericardial phenomenon or pericardial disease. Another problem which affects cardiac relaxation is restriction. This is predominantly a myocardial disease, and as I mentioned earlier, is a problem for the heart to relax properly. This most frequently occurs in all of us as we get older. Typically, relaxation is normal to the age of about 50, and from 50, relaxation starts to become sluggish and slow. And as a result, we become less reliant on passive filling and more reliant on our atrial kick. Of course, whilst aging is one of the main causes worldwide in terms of restriction abnormalities, there are various infiltrative processes such as amyloid or eosinophilic fibrosis, secondary to Löffler's syndrome, which can lead to marked restriction as well. Restrictive features can be identified on an echocardiogram, and they may explain why a patient may come in with systolic or parasystolic heart failure, have an echocardiogram which shows good left ventricular function, but a failure in restriction explains why the patient has developed marked heart failure symptoms. What do I mean by that? Well, as the heart is unable to accommodate all the blood which is returning from the venous circulation, pulmonary pressures rise, leading to pulmonary edema. So both the systolic pump is important for ejecting blood out of the heart, but also it's absolutely critical that the heart relaxes properly to accommodate all the blood which is returning from the rest of the body. When examining an echo report in detail, it's very important to look at both the systolic function and also to gauge a measure of the diastolic function, which is a measure of the restrictive nature of the heart, to ensure that this is adequate as well. There is no specific treatment currently for treating these restrictive problems, and most physicians and cardiologists recommend ACE inhibitors and A2 blockers. Let's do the next question, question 18. A 72-year-old Caucasian man is referred to outpatients with a 6-month history of progressive exertional dyspnea. His ankles swell as the day progresses. There is no associated chest discomfort. He's an ex-smoker of 3 years and drinks 12 pints of beer per week. He's not seen his GP in the previous 15 years. The only past history is that he has mild asthma as a child. His father died of myocardial infarction at age 65 years. Blood pressure is 150/86. Results of the investigation are as follows: renal function normal, cholesterol 6.8, ECG sinus rhythm with a left bundle branch block, echo dilated and impaired left ventricular function with ejection fraction of 30% and mild to moderate mitral regurgitation. No left ventricular hypertrophy was noted. What's the most likely underlying etiology? Do you think alcohol? Do you think coronary artery disease? Do you think hypertension, valvular heart disease, and viral myocarditis? The answer here is B, coronary artery disease. This gentleman is 72. He's male, has an elevated cholesterol, he's an ex-smoker, and has a family history of coronary artery disease. Whilst he does drink alcohol, his alcohol consumption is approximately 24 units per week, which is just falling within the recommendations of the Royal College of Physicians. However, I'm suspicious, given his symptoms of dyspnea, the fact he has a left bundle branch block, and the fact that he has an abnormal ECG. With this cardiovascular risk factor profile, of course it could be an underlying alcoholic etiology. In such a scenario, it would be absolutely essential to exclude coronary artery disease as the cause of his problems. In such a patient, the most appropriate investigation would be to proceed straight ahead to coronary angiography. This would give us a definitive answer and enable us to treat him appropriately should we find coronary artery disease. Next question. It's question 19. A 72-year-old man presents with 15 minutes of central crushing chest pain. An initial electrocardiogram shows 0.5 millimeters of ST elevation in leads V1 and V2. Has no previous cardiac history of note and reports no recent deterioration in exercise capacity. He's an ex-smoker of 20 cigarettes per day, but stopped smoking over 40 years ago. His lipids and diabetic status are unknown. On examination, he appears pale and sweaty with a blood pressure of 135/75 and bibasal crepitations. What's the most appropriate treatment? Would you give him TPA and aspirin? Would you give him aspirin, heparin, and repeat ECG in 15 minutes? Would you give him heparin only? Would you give him no treatment and repeat ECG in 15 minutes? Or would you give him streptokinase and aspirin? The answer here is B. Give him some aspirin, some low molecular weight heparin, and repeat the ECG in 15 minutes. The diagnostic criteria for a myocardial infarction is more than 2 millimeters of ST elevation in the chest leads, this be 2 or more concentric chest leads, or 1 millimeter of ST elevation in 2 of the limb leads. As he doesn't meet these criteria yet, I would treat him with a huge degree of caution, and it is likely that if we repeat an ECG, he may well go on to develop further ST elevation which would be highly suspicious of an underlying ischemic process. Now I'd like you to look at this chest radiograph. Does it look normal to you, or are there any abnormal features? You may have identified the boot-shaped heart, which may have prompted you to think of Fallot's tetralogy. The abnormal features of a Fallot's heart really are the fact that the heart has been rotated up from the apex normally being the lowest part on the left side of the chest, being rotated right up towards the left nipple. When you compare this to a normal chest radiograph, you can see that this really is quite marked, and indeed this is what was originally described on the abnormalities of the chest radiographs. Fallot's has four principal features. There is a large VSD. The VSD enables high pressure from the left side of the heart to travel into the right side of the heart. As a result, the right ventricle hypertrophies, getting thick. Further hypertrophication occurs as there is obstruction to blood through the pulmonary valve due to pulmonary stenosis. The fourth abnormal feature is that the aorta, rather sitting nicely centrally over the aortic outflow tract, sits astride the septum, the so-called overriding aorta. These four features are typical of Fallot's tetralogy, which is the commonest congenital cyanotic heart disease over 6 months of age. Now, generally speaking, we can make cyanosis worse by preventing blood travelling through the lungs. Now, it's easy to do this by just dropping systolic pressure. This can be done by sitting in a hot bath or lying on a hot beach, where you get marked vasodilation, and as a result the mean systolic pressure falls, and it's easier for blood to move from the right side of the heart through the VSD to the left side of the heart, bypassing the very stenosed pulmonary stenosis and therefore the lungs. In such scenarios, a patient may become cyanotic. This may lead to symptoms of worsening breathlessness. Nowadays, the treatment of choice for Fallot's is a total correction. However, previously in the 50s, William Blaylock, an American surgeon, pioneered the Blaylock-Taussig shunt. This shunt shunted blood from the subclavian artery into the pulmonary artery beyond the pulmonary stenosis, allowing an increase in the systemic saturations. This was a revolutionary procedure, and indeed some of the people who had this surgery as young children back in the 50s are still alive to this day. One must also consider other causes of a weak left radial pulse, other than those, of course, created by having your subclavian vein anastomosed to the pulmonary artery in the Blaylock-Taussig shunt. These would include coarctation, subclavian stenosis, which can be caused from atherosclerosis, arteritis or a cervical rib, embolism, or an etiological cause such as an arterial line. Ventricular septal defects occur with a frequency of around about 2 per 1,000. Many of these close spontaneously, typically 30 to 50%, as the heart changes in size from a very young infant to an adult. Like any congenital abnormality, if you have one, you need to be cautious that there may be others. And common associations include the sort of patent ductal arteriosus, aortic regurgitation, atrial septal defect, pulmonary stenosis, tetralogy of Fallot's, and coarctation. I'm now going to talk about hypertrophic obstructive cardiomyopathy. Particularly, I'm going to talk about how we can diagnose this clinically. Whilst it may not be the best mode of diagnosis, it's certainly something that candidates should be expected to have a grasp of. It's important to recognise that hypertrophic obstructive cardiomyopathy is primarily a muscular problem, whereby there's obstruction of blood flowing out of the left ventricle into the aorta as the muscles from both sides of the heart oppose one another. This is very different from, say, aortic stenosis, where the obstruction of blood flowing out from the heart is due to marked calcification. now going to talk about murmurs, and particularly hypertrophic obstructive cardiomyopathy. Whilst nowadays the routine investigations for looking at myocardial and valvular problems include echocardiography and magnetic resonance imaging, the examiner is expected to have a grasp of differentiating between HOCM and fixed valvular stenosis clinically. Fixed valvular stenoses are caused by a restriction of the valve leaflet and can be made to or certainly be augmented by increasing flow across them. This can be done by asking a patient to squat, which increases venous return. This is vastly different from the murmur created by HOCM, which is not a valvular problem, but is purely the result of the heart muscle from either side of the lumen impinging upon one another, restricting the outflow of blood. So what happens to our murmurs of aortic stenosis, for instance, and hypertrophic obstructive cardiomyopathy when we ask someone to squat? Well, one would expect that when someone squats, increased venous return, the aortic stenosis increases in intensity. But what happens to HOCM? Well, as well as the increase in venous return, by squatting, we increase our mean arterial pressure, as blood is unable to run down through the legs and into the peripheral tissues. If you look at the diagram in front of you, you can see at rest the gradient created in the hypertrophic cardiomyopathy heart is approximately 60 millimeters of mercury. This is calculated by subtracting the left ventricular pressure of 160 millimeters of mercury from that within the aorta of 100. Now, if we ask someone to squat, clamping off their arteries, increasing their mean blood pressure, the pressure rises in the aorta from 100 to 130, and as a result, the gradient between the left ventricle and the arteries decreased from 60 millimeters of mercury to 30. This results in the HOCM heart muscle not being held quite as closely in apposition as it would have been previously, and as a result, the volume of blood which is able to become ejected from the heart increases. In addition, the murmur intensity decreases. This is much the same as saying if you had a large VSD, there's often no murmur, whereas a very small VSD often creates a very loud murmur. So by increasing the mean systolic pressure, the apposition of the left ventricle is no longer as closely together as it would have been, and the murmur intensity falls. These two features can be reversed by performing a Valsalva. In such scenarios, the fixed valvular murmurs, such as aortic stenosis, will decrease in intensity as there's less blood flowing across it, but the hypertrophic obstructive murmurs would increase in intensity. The next table you can see in front of you compares aortic stenosis, predominantly valvular problem, with hypertrophic obstructive cardiomyopathy. And what we've done is we compared several of the physiological parameters which one may observe or identify between these two conditions. One could see in aortic stenosis there's a slow rising pulse, where in HOCM the pulse is jerky, as ejection is not smooth, as the actual muscle itself obstructs the outflow of blood. In both conditions, the heart is struggling very hard to eject all the blood, so it's very, very common to have a heaving apex. In aortic stenosis, the second heart sound is often soft, as the valves themselves cannot be heard closing properly. Whereas in HOCM, one would expect the aortic valve to be totally normal, and one should be able to hear a normal second heart sound. In aortic stenosis, it's common to have mixed valvular disease, so you have both a degree of stenosis and aortic regurgitation, where in HOCM, as I said, the valve is rarely affected. Finally, the table summarises what we've been discussing with regards to squat and Valsalva on the effects of the murmur intensity. HOCM itself is an autosomal dominant condition, at least in 50% of cases, and in those cases we know the genes in 75%. However, other things can cause the muscle to become hypertrophied, such as Friedreich's ataxia, pheochromocytomas, Noonan's disease, and Fabry's, which is alpha galactosidase deficiency. HOCM is frequently associated with mitral valve prolapse and Wolff-Parkinson-White. The next slide shows both histopathological features of HOCM and also the echocardiographic features of HOCM alongside that of a normal ventricle. Let's start by looking at the normal ventricle first. You can see the left ventricle is certainly a lot thicker and denser than the right ventricle, which is heavily trabeculated. But you can see a clear lumen within the left ventricle, which is where the blood flows during diastole. This is markedly different from the left ventricular HOCM heart, where you can see marked thickening of both the left and right ventricle, and the lumen is clearly markedly decreased in size. This will restrict blood flow, diminishing cardiac output markedly, and is likely to lead this patient becoming quite symptomatic. We can see on the lower side of the screen on the right the same features, but this time not in pathological specimens but at echocardiography. You can see a nice normal left ventricle at about the level of the mitral valves on the left, and on the right you can see the massively thickened left ventricle of subject with HOCM. You can once again note, when you compare the left ventricular chambers themselves between the normal and the abnormal heart, the intraluminal volume is massively diminished in the HOCM heart. Next question, question 20. A 45-year-old man presents with a strong family history of ischemic heart disease and atypical chest pain. Resting ECG and a handheld echocardiogram were both unremarkable. However, an exercise test shows J-point depression of 1 mm with a heart rate of 150 beats per minute at 88% of his target heart rate. What's the most appropriate next step? Do you think this chap should have coronary angiography, diabetic stress echocardiography, radionuclide myocardial perfusion scanning? Would you reassure and discharge him, or would you repeat his ECG exercise testing on anti-angiographic medication? The answer here is D. Now, when assessing any electrocardiogram, particularly in the scenario of looking at an exercise test, it's important that you look at the right part of the ST segment. This should be 80 milliseconds after the end of the QRS complex, and indeed in the next slide you can see this point identified. The reason for doing this is, of course, if you assess the ST segment in a subject who's tachycardic prior to the 80 milliseconds, it is likely that the electrocardiographic complex would be below the isoelectric line, returning up above the isoelectric line to form the next P wave, and this would apparently give a result of ST depression, which was upsloping. 80 milliseconds after this, however, this shouldn't be the case, and if you find either ST depression, which is downsloping, and upsloping at this point, I'd be more concerned. Now, this gentleman achieved 88% of his target heart rate with a good heart rate 150 with a poor story, and one would expect that at the J point, which is looking 80 milliseconds too early, if you only had 1 mm of ST depression there, it's very, very likely that if one was to look 80 milliseconds beyond, this would be, in fact, a normal exercise tolerance test. Generally speaking, in such scenarios, I would reassure and discharge the patient. If, however, there was particular concern and still a low threshold for thinking this was coronary ischemia, it may be reasonable to perform another non-invasive test, such as a stress echo, using dobutamine to increase both chronotropic and inotropic function of the heart, or a thallium or nuclear myocardial perfusion scan. If the exercise test was positive, or you had a strong degree of suspicion that this was positive, then of course the gold standard investigation is coronary angiography. Let's move on to the next question, question 21. A 72-year-old woman presents with 2 syncopal episodes and is brought to the emergency department by her daughter. The second episode has occurred on a particularly hot day after a family walk. She has a past history of hypertension and takes bendrafluozide. On admission to the emergency department, Her blood pressure is 165/115, and there is an ejection systolic murmur on auscultation of her chest that radiates to the carotids. What diagnosis best fits with this clinical picture? Do you think A, mitral regurgitation, B, hypertrophic cardiomyopathy, C, aortic stenosis, D, acute arrhythmia, or E, dehydration due to diuretics? The answer here is C, aortic stenosis. In the question, it clearly says she has an ejection systolic murmur which radiates up to her carotids. These would be characteristic features of aortic stenosis. One other key point which I'd like candidates to try and identify, and certainly as cardiologists we use regularly, is to go on to try and assess the severity of the aortic stenosis. One good way of doing this is to listen for the second aortic heart sound. If this is not present, it is likely that this is severe aortic stenosis. However, if it is present, the chances are it's only moderate or less severe grades of aortic stenosis. So one should always go to listen to that. A. Mitral regurgitation, B. Hypertrophic cardiomyopathy, C. Aortic stenosis, D. Acute arrhythmia, or E. Dehydration due to diuretics. The answer here is C. Aortic stenosis. In the question, it clearly says she has an ejection systolic murmur which radiates up to her carotids. These would be characteristic features of aortic stenosis. One other key point which I'd like candidates to try and identify, and certainly as cardiologists we use regularly, is to go on to try and assess the severity of the aortic stenosis. One good way of doing this is to listen for the second aortic heart sound. If this is not present, it is likely that this is severe aortic stenosis. However, if it is present, the chances are it's only moderate or less severe grades of aortic stenosis. So one should always go to listen to that, and it will give you a good idea at the bedside as to the severity of the aortic stenosis. So, what are the contraindications to exercise tolerance testing? Well, clearly there are some people who can't exercise. They may be wheelchair bound or with a fracture, or very elderly. But probably more likely the questions you're going to get in your exam is to be able to identify the patients in whom it's very difficult to interpret the ECG if they do exercise. This can be in people with marked hypertension, developing left ventricular hypertrophy and strain patterns, so abnormal repolarization, abnormal T-wave changes. Patients on digoxin, which can cause U-waves, which looks like inverted T-waves as well. Patients with abnormal conduction. This could be left bundle branch block or Wolff-Parkinson-White related, or it could be secondary to implantation of a pacemaker. Hopefully all of you would avoid exercising people in a dangerous scenario, and certainly this is something which you do very badly in your PACES examination if you suggested it as being a reasonable way to proceed with clinical investigation. And these would include never exercise someone with acute coronary syndrome, severe hypertension, so blood pressure more than 210. Be very cautious in people with aortic stenosis and HOCM. You're probably aware that we have several specialist indications for exercising people with aortic stenosis and HOCM, but this is really to assess the gradient, and it's in a very, very controlled environment in a doctor-led exercise tolerance test. To be very cautious in exercising people with left ventricular failure, as this has a propensity to potentially make the left ventricular failure worse, as is the case with flu and myocarditis. Be extremely cautious if you suspect someone having a dissection, as this could be potentially fatal. So positive exercise tests, what features would we be looking for? So classical angina, chest tightness, shortness of breath which occurs on exertion. ST depression, so we're looking for ST depression of more than 1.5 millimeters of mercury, 80 milliseconds after the J point. Remember, that's at the end of the QRS complex. Does the patient develop an arrhythmia? So this could be ventricular tachycardia, it could be atrial fibrillation, it could be pronounced ectopy, it could be ventricular fibrillation. But it's very important to document that, because this could be a sign that there's underlying ischemia. Is there ST elevation? Of course, this is something which would worry us hugely. One would hope as you exercise, as the exercise stopped, this would go away. But of course, you need to be very vigilant, and this would of course be a worrying sign of a positive exercise test. What happens to the blood pressure? Normally, during exercise, the systolic blood pressure should go up, and the diastolic blood pressure should go down, so there's a widening of the pulse pressure. If, however, the blood pressure fails to rise by more than 15 millimeters of mercury, or falls, that may suggest a positive test. The other group to consider is the equivocal group. So these are people who have less than 1 millimeter of ST depression, unable to do a proper Bruce protocol, have atypical symptoms. And they're often a group which we're presented with frequently. In this group of people, you may opt, if you have a very low clinical suspicion of ischemic heart disease, to offer a non-invasive test such as a thallium or a deep stress echocardiogram, or if you have a higher degree of suspicion, then a definitive test such as a coronary angiogram. The decision on which way to go is really based on your clinical decision, and you need to interpret each patient with all their risks on a case-by-case basis. False positive exercise tests do occur, and these occur more commonly in young females. Patients who hyperventilate, those with syndromes such as syndrome X, people who are anemic, that's likely to lead to ischemia, and people with left and right ventricular tract obstruction. Next, I've given you a list of contraindications to thrombolysis. Whilst, of course, thrombolysis rates are diminishing markedly in the UK with the advent of primary angioplasty services, it's important to know the criteria where one must be particularly cautious and when there are certainly absolute contraindications to thrombolysis. These would include surgery or major trauma in less than 2 weeks before wanting to thrombolyse, a head injury within 2 weeks, active bleeding within the last 10 days, an intracranial tumour or previous subarachnoid hemorrhage, a stroke less than 1 year before, a blood pressure in excess of 200 millimetres of mercury, a propensity to bleed, being pregnant, because one can bleed a lot from the placenta, and certainly would not want to thrombolyse a dissection, pericarditis, or a non-Q myocardial infarction. Relative contraindications include hemorrhagic diabetic retinopathy and hemorrhagic stroke. So dissection types, you should have a reasonable understanding of this. There are two main classifications, the DeBakey and the Stanford classifications. Let's start off with the DeBakey classification. Here's type 1, type 2 and type 3. Type 1 runs from the aortic root the whole length of the aorta, whereas type 2 just runs the short section from the aortic root going up to the ascending arch. Type 1 and type 2 DeBakey are the same as the Stanford type A classification. DeBakey type 3 starts in the descending arch and runs down the length of the aorta, and this is the same as the Stanford type B. Now it's important to differentiate between these two types, because certainly DeBakey type 1 and type 2 and Stanford type A we want to aggressively manage, often with urgent vascular surgery, whereas type 3, DeBakey or Stanford B, would manage often more conservatively. Now the reason for this is that anything which involves the aortic root or the head and neck vessels, if this was to dissect further or rupture, would obviously be very, very serious indeed. Whereas it's often possible in subjects with dissections which occur lower to be more conservative. Dissection can occur secondary to coarctation, hypertension, drug use such as cocaine, trauma, pregnancy, or diseases such as Marfan syndrome, Ehlers-Danlos, systemic lupus erythematosus, or giant cell arteritis. The next chest radiograph you see here is the subject with coarctation. You can clearly see a marked wasting in the descending aorta, which will clearly be very, very restrictive to blood flow going to the lower limbs and the organs of the abdomen. Mortality in coarctation is approximately 50% by the age of 30. It's frequently seen in Turner's syndrome. It coexists with a bicuspid aortic valve and other congenital abnormalities such as ventricular septal defect, patent ductal arteriosus, mitral valve disease, renal abnormalities, and barianeurysms. I'd like you to look at this next slide. It's an echocardiogram showing a parasternal long axis view and an apical view. What do you think the abnormal feature is here? You're correct if you identified a large left atrial myxoma attached to one of the mitral valve leaflets. This frequently comes up in the exam, and the features you should know are: it frequently occurs in elderly ladies, more commonly than men, accounts for 50% of all primary cardiac tumours, often associated with a low-grade fever, and ESR being elevated in approximately a third of all patients. Diagnostically, it may be possible to identify by a tumour plot at the time of the third heart sound. Patients with this condition often do very well, and the treatment of choice is surgical extraction. The next slide shows the major and minor criteria for rheumatic fever diagnosis. Whilst rheumatic fever is thankfully rare now amongst the indigenous population of the UK, immigrant populations and visitors will frequently present with rheumatic fever signs and symptoms. This may also be more relevant to candidates as there's been recent publications on this in the journal, and hence may come up as questions in forthcoming exams.
Today's broadcast will cover poisoning presentations, so-called toxidromes, and also the management of common poisonings, including the drugs that you see in front of you now. We'll go straight into question 1, and this covers poisoning with iron. So this question tells us we've got a 32-year-old man who's taken an unknown quantity of iron sulfate and has asked us which of the following answers is true. Well, A is unfortunately wrong, because the early features of toxicity are due to the corrosive physical nature of iron and normally cause nausea and vomiting and hemorrhagic gastritis. B is also wrong, because the dissolved tablets are not radiopaque, and it's only the undissolved tablets that you can sometimes see as a bezoar on radio imaging. C is in fact the correct answer, and initial hypoglycemia is often present, especially with significant ingestions. And significant ingestions are related to concentrations of over 80 micromoles per litre or 5 grams per decilitre of iron. Activated charcoal cannot be used in iron poisoning, as charcoal cannot bind to metals. Iron happens to be the most common accidental poisoning in children, though it is also still relatively common in adults. As I said, the initial symptoms related to the physical corrosive nature of the tablets. Then there appears a honeymoon period where the patient seems to improve for up to 24 hours. And then the systemic metabolic effects of the iron poisoning come into play, leading to hepatic failure and a profound metabolic acidosis. Mortality in this period is high, but if the patient does pull through, then there's often scarring of the gastrointestinal tract, leading to such conditions such as pyloric stenosis. As I've said, undissolved tablets are radiopaque only. If you can see a bezoar on radiography, then you can perform nasogastric lavage or whole bowel irrigation to remove the tablets. Activated charcoal does not bind metals and therefore is not used. And the specific treatment for iron poisoning is a chelating agent, desferrioxamine, which is also used in other iron overload conditions such as thalassemia major. Glycemic control is often altered in iron poisoning. We normally see an initial hypoglycemia, though if hepatic failure is a consequence of a serious overdose, then this may result in corresponding hypoglycemia. Serum levels are useful prognostically, as shown on the slide. We're now going to go on to a question regarding paracetamol overdose, which is the most common overdose in adults. See how you get along. Okay, so this question's telling us that there's a 16-year-old woman who presents 15 hours after ingesting 30 grams of paracetamol and 2 grams of dihydrocodeine. She's drowsy, but her GCS is 15, which is normal. She's borderline tachycardic, but is normotensive, and has small pupils, but has normal saturations on air. What's the most appropriate treatment for this patient? Well, there's no suggestion from the question that she's hypoglycemic. She may well be drowsy, but her GCS is 15, so A is wrong. Activated charcoal normally is only used within the first hour after a poisoning episode, unless the drug that's involved slows gastric emptying, which paracetamol and dihydrocodeine do not do. Gastric lavage is only indicated for poisoning such as iron, where you may have a bolus of tablets, which can then be removed en masse. The question does not suggest at any point that she's compromised by her opiate overdose from the dihydrocodeine. Although she's drowsy, her GCS is 15, and although she has pinpoint pupils, her saturations are 96% on air, therefore there's no indication for naloxone treatment. So the correct answer on this question is N-acetylcysteine intravenously. In a paracetamol overdose, the normal conjugated pathways that metabolize paracetamol are saturated. Any excess paracetamol is oxidized by mixed function oxidases to a toxic metabolite that we call NAPQI. This then binds to liver cell membranes, and a cascade is initiated which leads eventually to cell death and hepatic failure. We have an endogenous protein called glutathione which can conjugate NAPQI and allow it to be renally excreted safely. And N-acetylcysteine is a precursor to glutathione, so replenishes spent stores. When we're dealing with paracetamol overdoses, we take a serum level at 4 hours, and it is this level that we use to determine whether treatment with N-acetylcysteine is needed. we refer to a nomogram called the Rumack-Matthew nomogram, as shown here, and there are two lines, one representing normal patients and one representing high-risk patients. If at the time post-ingestion, as we can see here it starts at 4 hours, the patient's serum level is above the treatment line, then treatment with N-acetylcysteine must commence. This nomogram is not applicable to staggered overdoses, and in this case treatment should just be initiated straight away. And high-risk patients are considered to include patients with known chronic liver disease, alcoholics, patients who are HIV positive, or patients who are on enzyme-inducing drugs. N-acetylcysteine is best given within the first 8 hours, though it can be given at any time post-ingestion if it's indicated by the nomogram. Paracetamol overdoses are not normally toxic unless they contain more than 150 milligrams per kilogram of paracetamol. And as I said before, activated charcoal is only indicated if the ingestion is within the last hour. There are 4 phases to paracetamol overdose. The first phase lasts up to about 18 hours and is largely asymptomatic. From 18 hours to 3 days, there is a rise in the hepatic transaminase enzymes, associated often with right upper quadrant pain, nausea and vomiting. In the next 24 hours ensues hepatic failure leading to jaundice, a coagulopathy and encephalopathy. This often leads to a hepatorenal syndrome and renal failure, and this can then lead to death. It is during this period that we monitor the creatinine, the acid-base balance, and the prothrombin time, as these 3 blood tests are the most sensitive indicators for need for liver transplant and likely death. After 4 days, if the patient is going to survive, then there is resolution of symptoms and resolution of organ dysfunction back to normal. Our next question deals with an overdose of aspirin. Have a go at this and we'll see what the answer is. Okay, so we've got a 50-year-old lady with rheumatoid arthritis who takes an accidental overdose of aspirin, which is a salicylate. Shortly afterwards, she vomits and complains of tinnitus, sweating and dizziness, and we're asked what is the next best step in her management. Well, going through the options, acetylcysteine, as we had in the last question, is an antidote for specific paracetamol poisoning, so it's not indicated here. Hemodialysis can be used in aspirin overdose, though we need to know the serum levels of salicylate before we can decide that hemodialysis is needed. Aspirin overdose can lead to gastrotoxicity and hemorrhagic gastritis. There's no indication at the moment that this has happened, and if we were worried about this, we'd probably use more potent drugs such as a proton pump inhibitor rather than an antihistaminergic agent. There's no suggestion that her airway is compromised, and therefore intubation is also not indicated in this situation. Therefore the correct answer is gastric lavage and activated charcoal. Initially in aspirin overdose, there is a respiratory alkalosis due to direct central nervous system stimulation. Later, after the inorganic acid has been absorbed, there is a severe metabolic acidosis. Symptoms of salicylism include hyperventilation and non-cardiogenic pulmonary edema, encephalopathy and seizures, tinnitus and ototoxicity, which are very common, nausea, vomiting and gastrointestinal hemorrhage, and hypoglycemia. Activated charcoal is indicated if ingestion is within the first few hours only. Specific treatments to enhance excretion include urinary alkalization with sodium bicarbonate. However, in severe poisonings, hemodialysis is the treatment of choice. We decide to give hemodialysis if there is evidence of severe poisoning, such as persistent neurological symptoms, renal failure or pulmonary edema, refractory or profound acidosis, or serum levels of aspirin over 100 milligrams per deciliter. We're going on to question 4 now, which is asking us to consider a 40-year-old woman who's brought to A&E unconscious after an unknown overdose. Well, looking at this question, we'll start at the bottom and go upwards. Fluoxetine is a selective serotonin receptor inhibitor. An overdose can cause blurring of vision, fits, headaches, tremors, and the serotonin syndrome, which consists of agitation, dysarthria, tremor, myoclonus, and restlessness. This is a rare side effect, but it's a serious problem if you develop it, but it doesn't fit with the clinical scenario we are given. Chlorpromazine is a phenothiazine. Chlorpromazine is a phenothiazine drug, and poisoning with this drug causes dystonic reactions such as torticollis. Lithium is often used to treat bipolar depression. An overdose causes blurring of vision, diarrhea, vomiting, hypokalemia, drowsiness, ataxia, coarse tremors, dysarthria, seizures, psychosis, and eventually coma. Chlordiazepoxide is a benzodiazepine-like drug, An overdose with this drug causes respiratory depression and a reduced level of consciousness. The answer here is imipramine, which is a tricyclic antidepressant. Tricyclic antidepressants have 4 main pharmacological actions, and the toxic effects are due to these. They inhibit noradrenaline and serotonin reuptake at nerve terminals, they have an anticholinergic action, they have direct alpha-adrenergic blockade, and they have a direct sodium channel blockade on cardiac myocytes. They have a large volume of distribution and a long half-life, therefore they can stay around in the body for many days, and patients may need up to 5 days monitoring, especially for drugs such as amitriptyline. Patients present often with a sinus tachycardia, and the most important thing to look for on the ECG is the width of the QRS complex, as this is a guide to severity and need for treatment. If the QRS is less than 100 milliseconds, they are unlikely to develop seizures or arrhythmias. If it's over 160 milliseconds, they've got a 1 in 3 chance of developing seizures and a 1 in 2 chance of developing ventricular arrhythmia. They often have hypotension, which is commonly orthostatic due to the alpha-adrenergic blockade. Patients have mydriasis and urinary retention. In this case, activated charcoal could be useful for up to 12 hours post-ingestion due to delayed gastric emptying, which is an anticholinergic effect. If the QRS is more than 100 milliseconds, then the treatment of choice is intravenous sodium bicarbonate until the QRS has reduced in width. And if there are refractory ventricular arrhythmias, then these can be treated with amiodarone or in extreme situations Bertilium or lidocaine. Question 5 relates to poisoning with digoxin, and we'll consider this question next. Okay, so we have a 73-year-old man who presents with an overdose of digoxin, and we're asked to consider the following statements. So starting from the bottom, we can use digoxin-specific antibodies for bradycardia with hypotension, but only if we know that intravenous atropine has been used and has been unsuccessful. There's no suggestion in the question that this has been used, therefore this is wrong. Multi-dose activated charcoal has been shown to have beneficial effects in digoxin overdose, especially for those who've got signs of moderate to severe toxicity. DC cardioversion is not advised in the management of arrhythmias, as it has a high propensity to lead to asystole or ventricular fibrillation, and the digoxin-specific antibodies are made from sheep sera, and therefore a serum sickness-like condition can occur, though this is fortunately rare. The answer here is that calcium gluconate should not be given when hyperkalemia is present, and I'll explain this on the following slides. This schematic shows the sites of action of digoxin. It inhibits the sodium-potassium ATPase channel. Sodium cannot get out of the cell, so is instead counter-transported against calcium, which then has a higher concentration inside the myocyte, therefore leads to increased contractility as one of its effects. As we can see from this schematic, if the sodium-potassium ATPase channel is blocked, then hyperkalemia is one of the predictable side effects. The symptoms of digoxin overdose most commonly are palpitations, and digoxin is unique in that it can cause any arrhythmia from complete heart block to ventricular tachycardia or VF, though the most common arrhythmias are ventricular ectopics or a paroxysmal atrial tachycardia. Patients often present with syncope, confusion, dizziness, disturbed vision, nausea, vomiting or anorexia. As I said in the explanation, multi-dose activated charcoal is indicated for severe intoxications. It is important to treat any electrolyte abnormalities such as hyperkalemia, but paradoxically, in digoxin-specific hyperkalemia, calcium adjuncts actually worsen the risk of arrhythmia. And as I said before, DC cardioversion has a high risk of causing asystole or ventricular fibrillation, therefore is not advised. The specific treatment for digoxin toxicity is digoxin FAB fragments. This can cause a serum sickness-like syndrome. It's indicated for persistent hyperkalemia, or when serum levels are more than 10 nanograms per milliliter, or when we think there is an altered mental status attributable to digoxin only, or if there is a hemodynamically unstable tachyarrhythmia, or if there is a hemodynamically unstable bradyarrhythmia which has not responded to atropine first. So the next question asks us to consider a young boy who's taken some unknown antihypertensives who comes in bradycardic and hypotensive. So to answer this question, we need to have an idea of what the cause of his presentation is. The patient is hypotensive and bradycardic, And these two, in conjunction with knowing that he's taken an antihypertensive medication, should make us think of beta blockers in the first instance, and then certain calcium channel blockers secondarily. So we think this gentleman has taken some beta blockers, then we have to figure out which is the appropriate action at this point. Temporary pacing is an appropriate treatment for beta blockers if all other conservative treatments have failed. Putting a temporary wire is not a risk-free procedure, and we will not do this as a first treatment. External pacing is unlikely to work in a beta blocker overdose, as the threshold for capture will likely be too high. Adrenaline is unlikely to work either, as we've actually given a beta blocker, therefore the effects of adrenaline on the heart will be attenuated. Isoprenaline can work in a beta blocker overdose, though again, this is not the first line treatment, because the first line treatment is treatment with intravenous glucagon. As I said, the combination of hypotension and bradycardia should make one think immediately of beta blockers, then secondarily calcium channel blockers, and more rarely digoxin, though in this situation we've been told that he's taken a medicine that's been used for blood pressure control, therefore digoxin is out of the window. Of note, beta blockers also inhibit glycogenolysis and gluconeogenesis, and therefore they predispose to hypoglycemia, therefore frequent capillary blood glucose measurements are mandatory. There is no role for activated charcoal in beta blocker overdoses, and first line treatment is intravenous glucagon, first by bolus, then by infusion. Glucagon raises intracellular cyclic AMP levels by non-adrenergic mechanisms and therefore bypasses the beta blockade. The dose is often limited by severe nausea and vomiting. If the patient is bradycardic when they come in, then atropine should be given first, though there's no indication to give more than 3 mg as it's maximally antivagal at this dose. Isoprenaline can be tried after glucagon, though it's not clinically that effective, and temporary cardiac pacing is not often effective at restoring normal tension, although it may increase the heart rate significantly. If all else fails, then high-dose insulin dextrose infusions have been shown to work, and this is because it's thought that insulin has positively inotropic effects. In the specific case of a known atenolol overdose, as it's entirely renally excreted, then hemodialysis can be used. The next question considers carbon monoxide poisoning. Carbon monoxide poisoning is the most common fatal cause of accidental poisoning in the United Kingdom. And unfortunately, if you do have prior arteriosclerosis, then you are at increased mortality from the enforced hypoxia that carbon monoxide poisoning produces. Most people walking around do have carboxyhemoglobin levels less than 5%, but healthy smokers may well have levels up to 10%. So B is also wrong. One of the treatments for carbon monoxide poisoning is hyperbaric oxygen therapy, and pregnancy is a specific indication for this rather than being contraindication. This is because fetal hypoxia can be catastrophic, and we are trying to prevent this by the hyperbaric oxygen therapy. Sodium bicarbonate can correct minor metabolic acidoses, though administration reduces the amount of oxygen being relayed to the tissues, therefore can actually worsen the symptoms of carbon monoxide poisoning, therefore is not used. So here the answer is D. The treatment for carbon monoxide poisoning is removal from the source of carbon monoxide, administration of high flow oxygen by a tight-fitting non-rebreathed bag, and for specific indications, hyperbaric oxygen. And the indications are if the carbon monoxide level is more than 40%, if there's been a history of unconsciousness at all, if the patient is pregnant, if there are ECG changes, or if there are persistent neurological signs. The most common neurological signs are cerebellar signs, and as I said before, we don't like to use sodium bicarbonate, and if you've got pre-existing vascular disease, then as you might imagine, you're at increased morbidity and mortality. Question 8 relates to ethylene glycol, and this is the last question in this lecture. So ethylene glycol is one of the main ingredients in engine coolant and is a particularly efficient way to commit suicide, though not particularly nice. This gentleman has a severe metabolic acidosis with a bicarbonate of 2 and a low calcium. We're asked what we would do next after replacing the calcium. We have to consider two issues here. Firstly is that we need to treat specifically for the ethylene glycol overdose, but the thing that's going to kill this patient first is not the renal failure or the cardiotoxicity that the ethylene glycol will eventually cause, but the profound metabolic acidosis that he has. Therefore, here the answer is D. Strong sodium bicarbonate is not safe to give peripherally and has to be given via central line. After we've given this, treatment with either intravenous fomepizole or ethanol as an alcohol dehydrogenase inhibitor would be appropriate, and for severe overdoses, hemodialysis can be considered. The clinical presentation of ethylene glycol overdose is similar to alcohol excess but without the smell, so patients are confused, have a decreased conscious level and often ataxic. Ethylene glycol is broken down by alcohol dehydrogenase to oxalate, which then combines with calcium to form calcium oxalate crystals, which leads to hypercalcemia. The calcium oxalate crystals are directly nephrotoxic, so this can lead to renal failure. The oxalate is a strong inorganic acid, therefore leads to profound metabolic acidosis, and the oxalate can also be directly cardiotoxic. The degree of acidosis is predictive of mortality and is the first thing that needs to be corrected, so here we need to correct with strong bicarbonate solution via a central line. Alcohol dehydrogenase is the same enzyme that metabolizes alcohol as well as ethylene glycol, and therefore either a non-specific inhibitor such as alcohol or the specific inhibitor fomepizole can be used. And all electrolyte abnormalities in all overdoses need to be corrected, therefore in this situation calcium would need to be corrected. In a severe overdose, if the serum levels are over 500 milligrams per litre, then active elimination by hemodialysis can be used effectively. This brings us to the end of our first online broadcast covering clinical pharmacology and therapeutics, and in this lecture we have covered 8 common presentations of either accidental or deliberate overdose and gone through the management and presentations of each. Many thanks for listening, and I look forward to speaking to you again in our next lecture. Today we're going to cover 2 common prescribing issues in pregnancy. We're going to discuss the different types of adverse drug reactions, and then we're going to go on to the pharmacotherapy of pain and emesis, then talk about enzyme inhibition and enzyme induction. Our first question relates to a 28-week pregnant lady who is found to be hyperthyroid. Okay. Well, the management of hypothyroidism in pregnancy is similar to the management out of pregnancy, but with a few caveats. We can't do block and replace with cobimazole, as cobimazole crosses the placenta, and up to 10% of babies will cause neonatal hypothyroidism and a neonatal goiter. So therefore, D, B, and A are wrong here. However, if neonatal goiter does occur as a consequence of cobimazole treatment, then this disappears within a few weeks after birth. However, neonatal goiter in itself is not a simple diagnosis. The goiters can become so large that they can obstruct labour. So in this scenario, the only correct answer is C, because propylthiouracil does not cross the placenta. In pregnancy, radioactive iodine is absolutely contraindicated, as this will be teratogenic towards the fetus. It's not safe to breastfeed while on cobimazole propylthiouracil, as they are both excreted into the breast milk, and therefore they can cause neonatal hypothyroidism. Question 2 relates to a 24-year-old pregnant lady who's found to be hypertensive in pregnancy. We're asked to consider which is the most appropriate antihypertensive drug. There hasn't been a lot of use of losartan in pregnancy, but extrapolating from the data with enalapril, there are theoretical concerns with enalapril that it reduces fetal blood supply from the placenta and can adversely affect renal function. In addition, animal studies have demonstrated a potential association with fetal skull defects, so both A and E are not used in pregnancy. Hydrochlorothiazide is one of the thiazide group of diuretics, and they are specifically associated with fetal thrombocytopenia. There is no good evidence that doxycycline is safe in pregnancy, and no trials have been conducted, and therefore this is not routinely used in pregnancy either. Methyl-dopa has been used for over 40 years in pregnancy, and a seminal study in the 1970s showed that it was safe, and therefore methyl-dopa is considered to be first-line treatment for hypertension in pregnancy. We're slightly restricted in pregnancy, with which medicines have been shown to be safe, but blood pressure is important to control in pregnancy because uncontrolled hypertension puts the mother at risk of cerebral hemorrhage, but equally overzealous treatment of blood pressure puts the fetus at risk of placental underperfusion. Our armamentarium is limited, but the following 3 classes, methyl-dopa, beta blockers such as labetalol, and calcium channel blockers such as nifedipine, can be used in combination and are often all that's needed to control blood pressure adequately. Considering giving drugs in pregnancy, teratogenicity is worst in the first 16 weeks of pregnancy, and specific problems are encountered with specific drugs. Sodium valproate and the retinoid groups, which are often used for acne treatment, can cause neural tube defects. Phenytoin is associated with facial cleft abnormalities, warfarin with skeletal abnormalities, and lithium with cardiac abnormalities. Drugs that cross the placenta, such as carbimazole, can cause neonatal hypothyroidism, and gentamicin can cause a sensorineural deafness. As we've said already, propylthiouracil and carbimazole are not recommended for use if the mother is breastfeeding, and the neonates are at particular risk in their first month as they've got an immature metabolism. And absolute contraindications include amiodarone, which causes thyroid abnormalities, and cytotoxic or chloramphenicol drugs, which cause blood dyscrasias. Other drugs apart from the propylthiouracil and carbimazole which are not recommended include gold, iodide medicines, lithium, and estrogens for the following reasons. We're on to adverse drug reactions now, and I'd like you to consider the following question. So we have a 36-year-old man who has partial epilepsy, who's on vigabatrin and has now got a visual field defect. And we are asked what type of adverse drug reaction this is. Now, unfortunately, this isn't a question you can figure out. This is a question you either know or don't know. And here the answer is C, and the explanation is on the next slide. There are 5 different types of adverse drug reaction. The first type is type A, which is augmented. Now, this is a predictable dose-related effect. So when we give patients benjoflumethiazide, we know that we have to monitor their electrolytes as they can become hypokalemic. The more benjoflumethiazide we give them, the more hypokalemic they'll become. Type B is a bizarre reaction which is unpredictable. Now, these reactions are often idiosyncratic. We can't predict which patients get them. They're often very severe. They often have high morbidity and mortality. And an example of this would be Stevens-Johnson syndrome as a consequence of sulfasalazine. Not everyone gets Stevens-Johnson syndrome when they're given sulfasalazine. It doesn't matter how much you give of the sulfasalazine. Some people are just unlucky. The effect that we've had in this question of a visual field defect secondary to vigabatrin is a type C reaction, which is a continuous reaction, which is only apparent after prolonged drug use. This is a serious side effect of vigabatrin, and patients need to have perimetry performed before they're starting the drug and then routinely while they're on the drug to look out for this side effect. Type D reactions are classed as delayed reactions and are reactions that are either found to be teratogenic or carcinogenic. And an excellent example of this is thalidomide. When it was used in pregnancies in the 1970s, the babies were born with phocomelia. And type E reactions are so-called end-of-use reactions on withdrawal, and a good example of this is the rebound hypertension you get on stopping clonidine. We're on to the pharmacotherapy of pain control, and I'd like you to consider this 68-year-old gentleman with disseminated carcinoma of the prostate. Okay, so this gentleman's already on buprenorphine, which I hope you all know is a partial agonist at the opioid receptor. He's not well controlled, and we're asked, what can we do to make his pain control better? Well, if we start at the bottom, amitriptyline is a good analgesic, but only really for neuropathic pain. Now, this gentleman's likely to have bone pain, and therefore amitriptyline is not indicated in the situation. Diclofenac is a non-steroidal anti-inflammatory drug, which is useful if there is a large inflammatory component to his pain. Though with the extra history that he's got chronic renal impairment, we'd probably try to avoid non-steroidal anti-inflammatory drugs as they're a very common cause for worsening renal impairment. We could add morphine elixir to his therapy, though with buprenorphine being a partial agonist, when you mix a partial agonist with a full agonist such as morphine, the buprenorphine works in this situation as an antagonist, therefore will reduce the effect of the morphine, therefore A is wrong. And when we're titrating opioids to see what effect they have to get to the optimum dose, we want to use a fast-acting morphine, such as morphine elixir, rather than a sustained-release morphine, which can only be dosed twice a day, so that we can quickly up-titrate our analgesia to get adequate pain control quickly. Once he's on the morphine elixir, and we know the dose that he needs to be well pain controlled, we can then convert that to a sustained-release morphine for ease of administration twice a day. Our next question is also about pain in a patient who's on a methadone program. Okay, so we have a heroin addict who's on a methadone program, which is a long-acting opiate which is used to wean patients off heroin who's now developed pelvic fractures after a road traffic accident. We're asked about his analgesia. Let's look at the last three options, C, D and E. They all involve discontinuing his methadone. Now this is a bad idea because he will withdraw from his opiates and have an opiate withdrawal syndrome where he's agitated, tachycardic, may well develop diarrhea and other symptoms associated with this. For this reason, all the three bottom options are incorrect. Can we up-titrate his methadone? Well, as I said, methadone's got a long half-life, and therefore we can only dose it once a day, otherwise it will accumulate, and we are at risk of developing respiratory depression, which will then last for a long time given its half-life, and we may have to reverse this with a naloxone infusion. So the correct answer here is to continue on methadone, and then add in another agent, such as parenteral diclofenac, which in fracture pain, which is often very inflammatory from the hematoma that's formed, this will be very useful, and this is the correct answer. Our next question relates to antiemetic therapy following chemotherapy. Okay, we have a 24-year-old lady with acute leukemia who's undergoing chemotherapy. We're asked which is the best antiemetic for her. Both metoclopramide and prochlorperazine are antidopaminergic in action. Especially in young women, they have a high propensity to cause acute dystonic reactions such as torticollis or ocular gyrate crises, which are terrifying for patients. Therefore, both A and B are wrong. She's got severe vomiting, therefore really any oral medication is also wrong, as she's not going to be absorbing this, therefore both C and E are wrong. Therefore D is the correct answer, intravenous ondansetron. Ondansetron has been proven to be the most effective antiemetic post-chemotherapy. It's a very potent antagonist at the 5-HT3 receptor, and its main side effect is of headache. Specifically in chemotherapy-related emesis, dexamethasone has been shown to be a useful adjunct, and it can actually be given before the chemotherapy is given to prevent the predictable vomiting that will occur later. Our next question relates to a gentleman who's on simvastatin. So this gentleman's on simvastatin, and we should know that one of the main side effects of simvastatin is a myositis, which can then release creatine kinase. When there's release of creatine kinase, this can then crystallize in the kidneys to cause rhabdomyolysis and renal failure. We're asked what of the following interactions is most likely responsible for this presentation. So in normal doses, simvastatin doesn't often cause a myositis and rhabdomyolysis. And if it does so, it occurs on initial administration of the drug rather than later. So we think that there's an interaction with something else that he's taken, and we've got 5 options. Well, vitamin C and cod liver oil have no interaction with simvastatin metabolism. St. John's wort, cranberry juice and grapefruit juice all affect the cytochrome P450 system of mixed function oxidases. We have to figure out which one's the answer. Well, St. John's wort is actually an enzyme inducer, so it actually reduces the effect of many medications, so A is wrong. The answer here is grapefruit juice, and the reason is on the next slide. Simvastatin is metabolized on the 3A4 isoenzyme, and this is specifically inhibited by grapefruit juice. Cranberry juice inhibits this 2C9 isoenzyme, so this affects warfarin metabolism. Question 8 relates to a 45-year-old lady who's had a chest infection who's presented with a cardiac arrest. So in question 8 we've got a 45-year-old lady who smokes, who's had a cardiac arrest. She's had a chest infection, but she's penicillin allergic and been prescribed a macrolide antibiotic erythromycin. She's also got chronic vaginal candidiasis, and she's on an antifungal tablet. And we're asked what's the most likely cause of a cardiac arrest. Now, this being a clinical pharmacology question, there's likely to be a drug interaction here, and we have to think what drugs she could be on for her vaginal candidiasis. The most commonly prescribed antifungal in this country is ketoconazole, and we should know that ketoconazole is a potent enzyme inhibitor. Therefore, it's going to make her erythromycin more potent. One of the main side effects of erythromycin is that it prolongs your QT interval. When you have a prolonged QT interval, you're at high risk of developing Torsades de Pointes. Of note, enzyme inhibition is an instant phenomenon. It doesn't take time for this effect to occur, so even 1 or 2 doses can lead to potent inhibition and a profound increase in the effect of whatever drug the metabolism has been inhibited of. Question 9 relates to a 73-year-old man with chronic COPD. So this gentleman sounds like he's got relatively bad COPD, as he's on maximal inhaler therapy and also on theophylline tablets, and has been recently treated with antibiotics for a COPD exacerbation by his GP. Now he's presented with nausea, vomiting and tachycardia, and he's hypokalemic, but he can't remember what antibiotic he's on. We're asked to figure out which antibiotic he's on. Well, to answer this question, to start with, you need to realise that he's got signs and symptoms of theophylline overdose or theophylline toxicity, as evidenced by the nausea, vomiting, tachycardia and hypokalemia. So then we have to know which of these antibiotics is an enzyme inhibitor of theophylline metabolism. The penicillins aren't enzyme inhibitors, and likewise, neither the other beta-lactam-like antibiotics, the cephalosporins. So the only enzyme inhibitor in this list is the macrolide antibiotic clarithromycin. As I said, symptoms of theophylline poisoning include hyperemesis, agitation, tachycardia, hypoglycemia, dilated pupils and hypokalemia, and both macrolide antibiotics such as erythromycin and clarithromycin, and quinolone antibiotics such as ciprofloxacin can enzyme inhibit theophylline metabolism. Hepatic enzyme inhibition is a common question in the MRCP Part 1, and unfortunately this is just one of those lists that you have to learn. Of interest, acute alcohol ingestion is an enzyme inhibitor, and we'll see why that's interesting in a few slides' time. Our next question relates to an epileptic lady on carbamazepine. She'd been started on carbamazepine, and initially her levels were found to be therapeutic, though after a few days to weeks her dose had to be increased to achieve the same therapeutic level. And we're asked, what could cause this? Well, we've got